Welcome to the Cleveland Clinic's Respiratory Virtual Grand Rounds. I'm Dr. Raed Dweik, Director of the CME activity and Director of the Pulmonary Vascular Program in the Department of Pulmonary Allergy and Critical Care Medicine at the Cleveland Clinic. These Grand Rounds are case-based presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing patients with a certain disease. For today's presentation, I have asked Dr. Denis Hadjiliadis to provide you with an overview of the current diagnosis and management strategies for adult cystic fibrosis, including evaluation and treatment. Dr. Denis Hadjiliadis is the director of the Adult Cystic Fibrosis Program at the University of Pennsylvania, where he is also an associate professor of medicine. Dr. Hadjiliadis earned his Doctor of Medicine degree from the Faculty of Medicine at the University of Toronto in Canada. He completed his residency in internal medicine at the Mayo Clinic in Rochester, Minnesota, and his fellowship in pulmonary and critical care medicine at Duke University Medical Center in Durham, North Carolina. Dr. Hadjiliadis is a fellow of the American College of Chest Physicians and the Royal College of Physicians of Canada, and a member of several professional associations, including the American Thoracic Society and the Cystic Fibrosis Foundation Therapeutic and Development Network. Dr. Hadjiliadis' case-based presentation includes integrated audience response questions that are designed to help you test your knowledge as you follow along. Here is Dr. Hadjiliadis.
Hello, my name is Denis Hadjiliadis, and I'm the Adult Cystic Fibrosis Program Director at the University of Pennsylvania. I will talk to you about management strategies for adults with cystic fibrosis. And in my talk today, we're going to highlight a few of the more important issues that somebody might face when treating adults with cystic fibrosis, and also bring to the forefront some of the new treatments that we have available for it. First, I'm just going to disclose here are my disclosures. Like most people that are involved in cystic fibrosis have participated in clinical trials or have participated in advisory boards of the new treatments that are available for patients with cystic fibrosis. In addition, I received some grants from the Cystic Fibrosis Foundation for their clinical trials network, TDN, Therapeutic and Development, and also I have a small collaborating piece of an R1 in our center. We're studying CF-related diabetes. So what are the objectives for today? First of all, understand the diagnosis of cystic fibrosis, describe some of the manifestations, and also appropriate treatments, list appropriate treatments with adults for cystic fibrosis. Cystic fibrosis is characterized by A, nasal polyps, B, bronchiectasis and airway obstructions, C, pancreatic insufficiency or recurrent unexplained pancreatitis, D, salt loss syndromes, E, all of the above. And the correct answer is all of the above. All of them are features of cystic fibrosis. So we're going to do 3 case studies, and we will discuss them as we go along and learn about the objectives that are presented in the previous slide. So the first one is a case of a 45-year-old female who presents to her physician for a new visit. She's transferring her care locally now because she relocated. She's an ex-smoker. She has 12-pack years. She has 1-year history of a Mycobacterium avium complex infection that has been treated with triple drug regimen. The MAC was identified after a bronchoscopy for an abnormal CT scan that was done because of abdominal issues. The abdominal issues, as you can see below, is a history of recurrent pancreatitis that happened in a setting of drinking minimal alcohol. So she was having an occasional glass of wine at night, not very frequently, and she got pancreatitis, and there were no gallstones or no other reasons for it. So they did a CT scan, and they found some bronchiectasis at the bottom of her CT scan. They found the MAC on the bronchoscopy, and they also found methicillin-sensitive Staph aureus in her sputum and the bronchoscopy. While they had done some testing in the past during her pregnancies, they found that she had been a carrier of the delta F508 gene, which is the most common genetic abnormality found in cystic fibrosis. So one of the questions that came up to my colleague who saw her when she transferred here because her husband found a job in our institution was, might this lady have cystic fibrosis? So with this, I'm going to lead into going over what is cystic fibrosis and what are the diagnostic criteria. So first of all, we're going to start with the fact that cystic fibrosis is a clinical diagnosis in many situations, and there's a lot of phenotypic features that might be consistent with a diagnosis of cystic fibrosis. You can see there's 4 major areas of the body that are involved in patients with CF. So first of all, we have sinopulmonary disease, which is defined by having chronic cough and sputum production, having atelectasis and bronchiectasis and hyperinflation, having airway obstruction and air trapping. On sinus problems, we have nasal polyps being prominent, in addition with abnormalities with mucosal thickening and opacification of the sinuses. Also, in the more severe form, sometimes there is an absence of the frontal sinuses. And we also have colonization with infections that are typical for CF, like staph, non-typeable H flu, mucoid and non-mucoid Pseudomonas, Stenotrophomonas, Brucholderia cepacia, and also many of these patients have clubbing. The second, organ system that's affected very frequently is the GI and nutrition, problems that we focus. So in the classic form, CF causes meconium ileus in babies. It can cause similar syndromes in adults. That's called distal intestinal obstruction syndrome. And many times they have, because of the hard stool, rectal prolapse. Other features include pancreatic insufficiency with problems with fat replacement of the pancreas at a very young age in the classic form. But some of the milder forms sometimes lead to recurrent acute pancreatitis, which is not otherwise explained by other causes. It can also lead, of course, to chronic pancreatitis. Rarely, you can see as a main manifestation liver disease, including, that's usually mostly focal biliary cirrhosis, although liver disease is not that uncommon in cystic fibrosis as an accompanying feature of the disease. Finally, on the nutrition side, we have failure to thrive, and that's how many babies were diagnosed in the older days. And there is hypoproteinemia, edema. In addition, you have inability to absorb fat-soluble vitamins, which is A, D, E, and K. More difficult ones to define are salt loss syndromes, acute salt depletion, and chronic metabolic alkalosis. Of course, this one is, what's acute salt loss? Why, if it's hot outside, people will lose, salt. The question is, how do you define the person that lost more versus the next one? So that's a little more difficult to use as a diagnostic criteria, but that's another feature. And finally, for men, we have many times obstructive azoospermia and absence of the vas deferens, so we have male infertility. So if you have, any one of those, but especially if you have 2 of those systems that are affected, this is very likely to be something that suggests cystic fibrosis. So how do we go about diagnosing it with tests other than the clinical features? So most of the time, what we call the gold standard test, even at this point, is a sweat test. It's not exactly a gold standard because it's not perfect, but it's the best that we have right now. And a sweat test is a form of CFTR dysfunction. CFTR is the protein that's affected in cystic fibrosis, as most of you know. And sweat test is elevated in people with cystic fibrosis because CFTR doesn't work right. Okay, so if somebody comes, like the patient that we described before, with the symptoms that we described, we should do, a sweat test. If the sweat test is over 60, this is considered diagnostic of cystic fibrosis, and this is because there's very few people that do not have cystic fibrosis that have a sweat test over 60. So this diagnosis is made. We still can follow genotype to find out what's the underlying disease process that's creating this problem, but we have a diagnosis. There's an intermediate group that's sweat tests of 40 to 59 that suggests CFTR dysfunction, and there a DNA analysis might be useful in telling you if there is evidence in a genotype perspective, in a genetic perspective of CFTR dysfunction. And when you have a sweat test that's below 40, the diagnosis of cystic fibrosis is much less likely, but you have to use your clinical suspicion. If you have somebody that has very strong features, still that might suggest cystic fibrosis. So the other thing about this, sometimes you need to repeat the test because the test is not perfect. So that's why many of the features that you see in the intermediate category, you have repeat sweat testing after that. Okay. Now, how does the genotype fit into all this? I think we all know that cystic fibrosis is an autosomal recessive disease, so you need to have two bad genes from both your parents to develop, the disease. At this point, there is approximately 23 very well-accepted mutations that if you have two of those, irrespective of symptoms, you have cystic fibrosis. The reason for that is because they are common, but in addition to that, we know enough about them to know that they will lead to development of disease down the road, no matter what. However, there is approximately 2,000 known mutations in the CFTR gene. And however, some of those, they are not always, we do not know enough about them to know what their clinical course is. A recent paper suggested that instead of 23, there's probably more like 127 CF-causing mutations that really lead to manifestations of the disease at different points in life. So the truth is probably there's somewhere between the 23 and 127 that we can tell they cause features consistent with CF in everybody that has them. So this gives you, all the background for diagnostic information on how to go about making sure that somebody has cystic fibrosis. Next, I'm going to show you some slides about the distribution of CF diagnosis by age. So you can see that the vast majority of patients get diagnosed now at birth. There's prenatal testing that's done in the perinatal period. Babies are tested, and therefore we find them very early. And there's good reasons for that. We can treat them better, and we can prevent disease from happening. However, the tail of people that get diagnosed at late age has a few, blimps in there. So you can see that there's even people over 40, 31 to 40, 21 to 30, and 16 to 20. And, those are usually people that don't have those manifestations early on. So they might be more difficult to pick out in the earlier phase. But it's not uncommon to find some patients that are diagnosed pretty late. So I'm going to give you some information about, our patient. So genetic testing was done, and what was found is that she has delta F508 that we knew about, and a second mutation that's called 711 plus 3A to G. Don't ask, that's the name. You don't have to know anything about that. She also had a sweat testing done that showed values of 77 and 79, which are both consistent with a diagnosis of cystic fibrosis. Now, her genetics alone would not, tell us that she has cystic fibrosis because that second mutation that she has is not a CF-causing mutation. So I want to, clarify here the difference between a CFTR mutation and a CF-causing mutation. As we said, we kind of talked about what are CF-causing mutations. They are the ones that will cause cystic fibrosis features no matter what. However, there is other mutations of CFTR mutations that we do not know what they do. Some of them, they might cause CF in some patients, but there might be some patients that don't develop cystic fibrosis. And that might be related to other interactions with the environment, with other, genes, genetic modifiers. So they all might cause some form of CFTR dysfunction, but it's not severe enough to cause the manifestations that we know. There are also mutations with no known clinical consequence because they do not, as far as we know, they haven't caused disease. And if we get enough information about those, then they get off the list of, they become polymorphisms, as we call them many times, rather than bad mutations. And there's some that's so rare that we do not know anything about them. So that's why this is important. Now, one other, issue that comes up, so, okay, we found that this lady has cystic fibrosis. So what? What's the big deal about it? Well, there is some evidence that has been published right now that these patients can have significant disease. So this is a paper from a very large cohort of patients at the University of Colorado in a National Jewish Hospital, Dr. Nick, where it has shown several things of interest. First of all, in the graph below at the bottom, you can see that in the blue dotted line, the adult diagnosed patients, and in the solid line, the conventional diagnosis. Okay. You can see that both of them lose lung function in a relatively steady state. So even though these patients might have milder mutations that are manifested later, they're still at risk of lung function loss and therefore disability and problems. Okay. So this is an important disease. It's not, minor, so it would be good to find it out. In the graphs above, you can see in the green dotted lines how the lung function of patients in the cystic fibrosis registry changes over years. So you can see there's probably over a 4-year period and about 2 to 3% loss in years following a diagnosis. And that's any kind of patients that we have in this. However, as you can see here in the University of Colorado on the right graph, when you look at men and women, when they come at the time of the diagnosis, they improve their lung function and then they keep it steady. Okay? So that shows that care at an adult cystic fibrosis center might stabilize lung function. You look at it in a different way, and you look at people that were treated at the University of Colorado and people that were treated in other CF centers, and you can see the same feature. So that suggests that finding out that somebody has cystic fibrosis, even at a late stage, might lead to some improvement in their lung function or stabilization, and therefore there might be some benefit of having the diagnosis and being treated at a specialized center. Let alone from that might be a significant in being able to get medications approved by the insurances that are appropriate for cystic fibrosis. It might be important for family planning. What is less clear is whether this would affect things like life insurance if you have a diagnosis of cystic fibrosis, which, even though it might be mild, life insurance might not recognize that. Okay, so we're going to stop from this case and now go to the second case study that's going to show something different. And it's going to focus more on new medications and new treatments. This is a 39-year-old male who had cystic fibrosis diagnosed in childhood. He had bronchiectasis, moderate lung dysfunction, pancreatic insufficiency, and sinusitis, and he presented to our clinic with increased respiratory symptoms. Has not been in clinic for more than 2 years, 2 years and a couple of months. He recently quit smoking, and he comes in with a lung function that's much worse compared to the one that he had about 26 months ago. So you can see that his FEV1 has decreased from 63 to 34%, and there has been a slower but significant decline in his vital capacity too. He has a weight loss also of 12 pounds, and his BMI went from 24 to 22.8. We know he has had Pseudomonas in the sputum in the past, and what happened is he has not been doing any of his therapies. He ran out of pancreatic enzymes, so therefore he started losing weight, but he hasn't done many of his therapies. This gentleman works in construction sites, so therefore he likes, he's a little bit of macho kind, if we might say that. He doesn't like to be identified as having CF or being sick, so he stopped a lot of his therapies from that perspective. And he was brought in by his wife when he kept coughing uncontrollably. This is his X-ray. It's typical of cystic fibrosis. You can see some features of bronchiectasis. This is airways that are facing us straight on. And here's some tram tracking with some cylindrical bronchiectasis in other airways as they go, towards the periphery. But he has no pneumonia. So what therapy should this person be on? So first of all, he has Pseudomonas. So this is guidelines that were published for chronic pulmonary therapies by Dr. Mogazel and a group of experts from the Cystic Fibrosis Foundation. So first of all, he has moderate to severe disease. A lung function between 25 and 75% is considered that. He has Pseudomonas in his sputum. So there is a A-level recommendation of being on inhaled tobramycin on a chronic basis. Also on being dornase-alpha, which is a mucolytic agent that breaks down DNA. This is also a level A evidence. Both of them can improve lung function and decrease exacerbations and also improve quality of life. There is also evidence that he should be on inhaled hypertonic saline. It's a little slower, the evidence, but also can decrease exacerbations. There's also evidence that he could be on azithromycin, which works more as an anti-inflammatory probably agent or a quorum-sensing agent in patients that have chronic Pseudomonas aeruginosa, and it can improve exacerbations and lung function. Evidence there is more of at the B level. In addition, a new antibiotic that could be used is inhaled aztreonam, which also has evidence similar to tobramycin, although less time in it, that it can improve the above problems. Another new medication that she could be eligible based on his genotype is ivacaftor. So we're going to talk a little more about this medication and how it applies to this case, but it actually corrects part of the underlying disease if you have a certain mutation that's called Z551D. And it has been approved approximately 2 years ago for use in patients with cystic fibrosis. At the time that our patient showed up, it wasn't approved, but we're expecting its approval from any time. So at that time, we gave him all the above medications, no hypertonic saline because he got bronchospasm, so he doesn't tolerate it, and because also we are not giving 2 inhaled antibiotics at the same time. So you got dornase-alpha, tobramycin inhalation solution, and azithromycin. We gave him back his pancreatic enzymes, and we gave him levofloxacin for 3 weeks for his exacerbation. Many people would argue that we need to do intravenous antibiotic therapy for this gentleman, and we were very close to doing that, but he had been on so few therapies that we felt we can try with the oral antibiotics first very aggressively and see what we do with that. In addition, we gave him a new nebulizers, and we talked about doing airway clearance. He came back in 2 weeks with a significant improvement in his lung function, and he also had gained 6 pounds already. So the plan seemed to be working appropriately. In addition to that, as we said, he had that mutation. So when he came back to clinic, now we had approval of that new medication, ivacaftor, that he would be eligible to receive. So let's talk a little bit about ivacaftor. To do that, we're going to talk first about the different classes of CF mutations. So there is 6 classes of cystic fibrosis mutations. The class 1 is one that you don't make mRNA, and there's a stop codon on the mRNA, and therefore what happens is you don't make enough protein, and those are stop codon mutations. Class 2 are ones that the delta F508 gets misfolded, and therefore does not pass quality control by the cell, and it ends up stuck in the endoplasmic reticulum and then destroyed. Delta F508 is the most common mutation. That's the class that it is in. Class 3 mutations are ones where you have the CFTR in the surface cell where it's supposed to work. However, it does not, the channel doesn't open. That's the class 3 mutation, Z551D, that we talked about. Okay? And then there's class 4 mutations, which are the channel is in the surface. It does open, but doesn't conduct enough. It has the defective protein conductors. So functionally, you have much less CFTR function, and it leads to more problems. R1 and 7H is the most common mutation here. Class 5 is a situation where you would make the right protein, but for some reason, because of splicing issues, you would have reduced amounts of CFTR, and therefore functionally you have CFTR dysfunction. I'm sorry I'm using the functional word all the time. And class 6 is a case where you can have accelerated turnover of the protein from the cell surface, and that leads to, again, functionally decreased amounts of CFTR in the cell surface. Now, there is efforts to try and approve medications for most of those mutations. Before I go through that, I'm going to say that if you have your milder mutation out of the 2 that you have defines whether you are on the milder or on the more severe form. Class 1, 2, and 3 are what we call more severe. Those are associated with pancreatic insufficiency. So most of those patients get diagnosed at birth or very early on, because it's very easy to find out that they have failure to thrive and more severe, problems. People class 4, 5, and 6 tend to be a little milder, although in the lung disease there's a lot of overlap. The pancreas is the one that defines those things a little better. The medications that they are trying to find for other things include altalurin for class 1 mutations, which is going to have a repeat phase 3 trial. And right now for the delta F508, there is ivacaftor and lumacaftor trials, which it's supposed to help class 2 mutations, delta F508, get both folded properly so that it bypasses the endoplasmic reticulum, makes it up here to the cell surface, and then the ivacaftor can open the channel. So that's another, one that's on phase 3 trials right now. Second question is, in patients with cystic fibrosis, moderate lung dysfunction, FEV1 between 25 and 75%, and Pseudomonas aeruginosa in their cultures, the following medications are recommended for chronic management by the Cystic Fibrosis Foundation. So A is dornase-alpha, B hypertonic saline, C azithromycin, D tobramycin inhalation solution, and aztreonam for inhalation, E all of the above. And the answer is all of the above. That's the correct answer as we presented the evidence in the guidelines. Ivacaftor is approved for use in which group of patients with cystic fibrosis? A, all patients with CF. B, patients with specific mutation, G551D. C, all patients with delta F508 mutation. D, all patients without delta F508 mutation. Correct answer is B. Ivacaftor is approved for patients with G551D mutation. So ivacaftor had actually some major trials that showed some major improvement in many outcomes in cystic fibrosis, better than any of the other therapies that have been approved in the last 20 years. So first of all, it increased the sweat test of these patients by about 40 micromoles 2 weeks after medication initiation. So the sweat test went from about 100, which is the average sweat test of people that have this mutation, to about 60, which, if you remember, that's basically the borderline diagnosis of cystic fibrosis. So that was a huge, improvement on a biomarker of CFTR dysfunction. But beyond that, in every other clinically significant outcome, it hit good endpoint. So we had a 10% improvement, absolute improvement in FEV1 that happened quickly and was sustained. We saw an improvement in CFQR, which is a quality of life questionnaire. We saw an improvement in weight, which is a sign of improved in gut function and less exacerbations, and a decrease in exacerbations that happened very quickly and then sustained over time with the patients. So this is a good medication from our perspective. So once it got approved, we gave him ivacaftor in addition to the other medications. We followed him now for another 1.5 years. He has had no more exacerbations. His weight is now 163 pounds. He topped out 170, and that's a BMI of about 24. His lungs function is 2.45 FEV1, 60% of predicted, with an FVC of 72%, which is the best in 4 years. It's basically very similar to what it was before he disappeared from our clinic. So this is, for now at least, a significant success story, and he managed to remain off cigarettes, which is very good from our perspective. Okay, now we go to the third case, which is going to show something else, that's significant in cystic fibrosis at the current time. So this is one of a 39-year-old patient with cystic fibrosis who was diagnosed in childhood. He has pancreatic insufficiency, he has sinusitis, distal intestinal obstruction syndrome, and he also had some mitral valve disease, which is not related to cystic fibrosis. This is in mutations. He has delta F508, which is the common one, and the second one is stop codon mutation, so he's supposed to have severe disease. He has a sweat test of 121. His cultures have grown a lot of things. Most recently, most significantly, we've had Pseudomonas, Stenotrophomonas, and at some point he had Mycobacterium canzanzi, for which he was treated and cured. His BMI was 22.3 at the time, lung function 90%. So despite the fact that he has severe mutations, you can see the variability of the disease. He has very good lung function. At the time of his annual screening, we did a glucose tolerance test because diabetes is not an uncommon manifestation of cystic fibrosis. And we found out that he had a 1-hour blood sugar of 264 despite a normal fasting and a 2-hour of 176. That's consistent with impaired glucose tolerance or indeterminate glucose tolerance because he spikes over 200 and he has impaired based on the 2-hour. So even though this does not make him diabetic, it shows some significant inability to deal with blood sugar, with sugar loss. His hemoglobin 1C was 6, which wouldn't meet diagnostic criteria. So the question is, how do we manage this? And is this significant? So a little bit of background first. So diabetes and cystic fibrosis go together. In the early days, when unfortunately children died young, it used to be told that the endocrine pancreas is not affected by CF. And you can see that at the age of 10, diabetes is not very common. However, as people grow older, it becomes more and more common, and I would say as many as 50% of adults will have diabetes at some point in their life. Okay? And you can see the prevalence increases to about 45% at the age of 40, and that doesn't include the people that died before that. Okay? This drop-off that we see in the older patients is probably related to the fact that the people that survive a lot more than that tend to have different type of CFTR dysfunction, and therefore they are less likely probably to develop all the manifestations of the disease. So the question is, why is this important? So we're going to go to that, but first I'm going to go to a few, definitions. So this is, the glucose on the y-axis and the time after the glucose administration for a glucose tolerance test to help us define different patients. The blue line is easy. They have fasting hyperglycemia, they have diabetes. The red line is also easy. That's normal glucose tolerance. You go a little high, 30 minutes, and then you come down to normal. But there's a lot of groups in between. So there's diabetes without fasting hyperglycemia. That's the green line, where what you do is at 1 hour and 2 hours, you go above 200, therefore you have diabetes, okay, even though you're okay at fasting. And then there's the group that has impaired glucose tolerance, which spikes a little bit, like our patient, at 1 hour, but then it comes down, but very slowly. Finally, there's another group, the indeterminate, which a lot of our patients pass through first. What happens is they spike quickly, and then they come down to normal, or sometimes they overcorrect and they go below, their fasting level. So our patient is in the orange line. So at this point, and the other thing that I want to say, and I'm going to show you in the next few slides, that diabetes can have detrimental effects in cystic fibrosis. So we wanted, to make sure that the patient does certain things that are appropriate to make sure that his blood sugars don't spike too much. So we gave him instructions on appropriate diet modifications while preserving his calories because he needs to have a high-calorie diet having cystic fibrosis. However, the patient has fear of insulin injections and does not want to let his sugar go high at any point. So what he did is he restricted his calories on his own, and his BMI dropped significantly to a BMI of 19.8, which is the lowest that he has had in many years. He also declined his lung function, and he needed a course of cefepime and tobramycin at the same time. And you can see the FEV1 is down to 82% now, and his vital capacity has gone down to 90. So why did we care about it? Why didn't we let him, run a little high? So there's a couple of papers, a couple of slides here that I'm going to show you that if you have abnormal glucose tolerance, it's associated with pulmonary function decline. So you can see normal, that's the decline that you have over the time period that the study was done by Mila showed. If you have impaired, you lose 2%, and you go, more if you have CFRD. And insulin deficiency, which is another surrogate of looking, at this, shows the same thing. So if you have, problems, then you end up, losing more lung function. So what's different about, CF-related diabetes and regular diabetes? So this is important to remember, is that in regular diabetes, we want, a regular calories, regular energy if you're a normal BMI. In CF, we need higher calories. We need more calories from fat. And we need to allow sometimes the sugars, but we have to, be careful on how we use those. In addition to that, is we still use a lot of carbohydrate as part of energy. We also, ask them to make sure that they have significant protein intake, and we make sure that they have enough salt intake, and those are the significant things that we allow them. Here's another paper here that suggests, again, the same thing, that if you have CF-related diabetes, you can have worse outcomes if it's untreated. So this is 3 different cohort studies from the University of Minnesota that picked on this relatively early, and what it showed is that you can see in the solid lines the women with diabetes, and in the solid blue lines the men with diabetes. They had relatively increased mortality compared to the people, the dotted lines, which don't have diabetes. As the times, went along, they started treating them better, and you can see that both groups are starting to have similar mortality as time, goes along. Okay, so this is a sign that, cystic fibrosis diabetes is significant. Is the following are true about cystic fibrosis-related diabetes. A, it is rare. B, it has no significant consequences. C, it is associated with worse pulmonary function and nutritional outcomes and death. D, treatment is ineffective. The answer is C. So it has been associated with all those outcomes. It is not rare. It has significant consequences, and treatment can lead to somewhat improved outcomes. So we talked about the differences that we do for the diet and why this is significant. So what did we do about this? We had many discussions. We liberalized his carbohydrates. Symptoms improved over time, and we had no more exacerbations. He gained a lot of the weight back. His hemoglobin 1C remained at 6.2, and he used prandial insulin with a low carb ratio and good control. And the last lung function we have is 95% at this point. So that's a significant, effect. So those 3 cases illustrate 3 important points. One is that we have a lot of new treatments with CF current, and then some that are going to come down, hopefully in the next few years, to change the course of the disease. Second, diabetes is a very important marker of progression of disease, and we need to treat it aggressively to get good success. And the third part is that making a CF diagnosis, even in older patients, is not impossible and sometimes might lead to improved outcomes and improved possibilities. And that's it. Thank you very much.
Thank you, Denis. In this case-based presentation, Dr. Hadjiliadis discussed the changing demographics of cystic fibrosis. The vast majority of patients are still diagnosed at birth, but many are diagnosed at an older age, and many are living into adulthood. He went over the clinical features and diagnostic criteria of cystic fibrosis in adults, including the utility of genetic and sweat chloride testing in establishing the clinical diagnosis of cystic fibrosis in adults. Dr. Hadjiliadis also discussed the nuances of therapy in adults with cystic fibrosis, including the role of newer, recently approved therapies. He emphasized the importance of identifying and treating glucose intolerance and diabetes in this patient population and how it is different from diabetes in individuals without cystic fibrosis. I hope that you found Dr. Hadjiliadis' presentation on adult cystic fibrosis to be a useful update on this topic, and that will help you with your day-to-day management of patients with pulmonary as well as extrapulmonary manifestations of this disease. Finally, on behalf of myself, Dr. Hadjiliadis, the Respiratory Institute, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.